The field of metabolic liver disease has kind of exploded onto the scene in the last 25 years, primarily because we don't think the disease existed in great measure before then. And that speaks to the genesis of the disease, which is not completely understood, but is certainly known to be associated with obesity, type 2 diabetes, hypertension, and hyperlipidemia, which collectively are often called the metabolic syndrome. The most obvious link to changing diet is the pervasiveness of fructose or corn syrup, which has been used widely as a sweetener instead of conventional sugar because it's cheaper to make and to introduce into foods. And fructose, unlike other kinds of sugars, turns directly to fat when it enters the liver. It may be that what we eat and what we're exposed to also changes the nature of the bacteria in our intestines, also known as the microbiome. And there's a mounting body of evidence that implicates a changing microbiome over the last 25 or 30 years as part and parcel of the drive to eat more. Conditions in the liver don't generate any specific symptoms. It's often overlooked both by the patient and by the providers, and they don't look for liver disease because they're too busy managing the diabetes and the obesity and the hyperlipidemia. And that's unfortunate because those patients probably could have had better outcomes if their asymptomatic liver disease had been diagnosed much earlier. We've learned now that up to 70% of type 2 diabetics have some abnormal fat or stiffness in the liver. The economic cost and the lost work and the impact on quality of life of this disease is extraordinary.
And what message would you have for the audience today? How can they optimize their own liver health going forward?
Very important question, and I think the simple answer is
let's talk about diseases of the liver, specifically arising from metabolic dysfunction. Non-alcoholic fatty liver disease, or to give it its acronym, NAFLD, it's estimated that 1 in 4 people alive have this particular condition. But first, can we talk about how it was only discovered as recently as the early 1980s, and that its name arose, the non-alcoholic part arose by virtue of the need to differentiate it from fatty liver disease, which up to that point was only associated with alcoholism?
Pleasure to join you, Matthew. The field of metabolic liver disease has kind of exploded onto the scene in the last 25 years, primarily because we don't think the disease existed in great measure before then. And that speaks to the genesis of the disease, which is not completely understood, but is certainly known to be associated with obesity, type 2 diabetes, hypertension, and hyperlipidemia, which collectively are often called the metabolic syndrome. So this is a disease of the modern age, and therefore it was really only described when it began to appear in numbers in the 1980s. It really only entered our consciousness as liver experts maybe in the 1990s at the earliest, and now, of course, is front and center in the world of liver disease. I do need to update you and the listeners on the terminology. The term non-alcoholic fatty liver disease was thought to be somewhat pejorative by introducing the word alcohol when, in fact, alcohol has nothing to do with it in most cases. And so last year, there was an international consensus to rename the disease, and it's now called Metabolic Dysfunction Associated Liver Disease, or MASLD. That's the former term NAFLD. And the former term NASH is now called MASH, which is Metabolic Dysfunction Associated Steatohepatitis. And that introduces two advantages. One is there's no mention of alcohol. It's not strange. It's a little strange to name a disease for what it's not. And so they avoided that. And secondly, it allows for some sub-classification of the disease to include those patients or people who have not only MASH, but may also drink alcohol, which compounds the disease. So we're now using the term MASLD and MASH, but the disease definitions haven't really changed.
If we could dive just a little bit deeper, how does the food we eat, because I presume this is where the problem starts, how does the food we eat end up making our liver fat? And then what role does something like insulin resistance play in this?
Certainly, the disease is associated with obesity and therefore increased intake. The most obvious link to changing diet is the pervasiveness of fructose or corn syrup, which has been used widely as a sweetener instead of conventional sugar because it's cheaper to make and to introduce into foods. And fructose, unlike other kinds of sugars, turns directly to fat when it enters the liver. So that's one reason. Another, perhaps more subtle reason may be that what we eat and what we're exposed to also changes the nature of the bacteria in our intestines, also known as the microbiome. And there's a mounting body of evidence that implicates a changing microbiome over the last 25 or 30 years as part and parcel of the drive to eat more, and therefore the accumulation of fat in the liver and the acquisition of the metabolic syndrome. With respect to type 2 diabetes and insulin resistance, that's known to be among the most important drivers of fatty liver or steatotic liver disease. Of course, many of the emerging treatments are directed specifically at treating diabetes or insulin resistance. So, for example, the explosion of drugs that are so-called GLP-1 agonists are primarily, or were developed primarily as diabetes treatments. Now, it turns out that at higher dose, they also can induce substantial weight loss, and we know weight loss independently can improve the liver's health. So I think the GLP-1 agonists, which here in the States go by the name of semaglutide or Ozempic, Wegovy, and then combination drugs as well. These are likely here to stay because they not only help correct insulin resistance directly, but indirectly they improve the situation by inducing weight loss.
Just to revisit those acronyms again that you introduced, the MASLD and the MASH, if my understanding is correct, and please correct me if I'm wrong here, but does that refer to a spectrum of severity of conditions?
Yes, it does. So MASLD is kind of an umbrella term, much as the old NAFLD was. It refers to any condition with fat in the liver, whether or not it's associated with inflammation. Now, in fact, you mentioned the prevalence of the disease of MASLD or NAFLD as somewhere around 25%. That's probably conservative. Well, recent studies suggest it's upwards of 30%, 30 to 35%. And interestingly, it's not restricted by any means to the U.S. and Western Europe. It's highly prevalent in the Middle East and North Africa, as well as Asia, the Far East in particular. And there are some genetic determinants that probably increase the risk of developing MASH at lower weight. So, for example, Asians have a higher propensity to develop so-called lean MASH, where they have all the markers of fat in the liver and the problems therein, and yet their body mass index is normal. So just to come back to your question, MASLD can either be fat alone or fat with inflammation and fibrosis. The latter is called MASH. So in reality, the treatments that are being developed primarily for MASH are only in those patients who not only have fat, but also have inflammation and scarring developing.
You referenced the statistic I gave initially, and you said that was an underreporting really of the case numbers out there at the moment. Is that in part because you can be slim and still have this fatty liver disease? So you can basically be walking around like you're an average person with a regular or normal BMI and still have this disease and not even know it?
That's absolutely true, but that really constitutes a minority of the patients, particularly in Western or Caucasian civilizations where the prevalence of lean MASH is low. Even in Asia, it's probably no more than 10%. So the bulk of patients with MASH are overweight or obese. And the bigger problem is that patients who typically have MASH have a lot of comorbidities. They're diabetic. They may have heart disease risk, arthritis from being overweight, and a lot of comorbidities that draw much more attention. And because the conditions in the liver don't generate any specific symptoms, it's often overlooked both by the patient and by the providers. And they don't look for liver disease because they're too busy managing the diabetes and the obesity and the hyperlipidemia. So it's not at all unusual for patients to show up in the hospital with very advanced liver disease, not knowing that for years they've been developing this progressive state of inflammation and scarring. And that's unfortunate because those patients probably could have had better outlook or better outcomes if their asymptomatic liver disease had been diagnosed much earlier.
So really, whether you're slim or whether you have some of these comorbidities that you're talking about, really the best approach is to be proactive as far as the liver health is concerned. But how is that possible in terms of, would you have to do assays for particular liver function biomarkers, or is there some kind of diagnostic tool that's used in order to determine the health of the liver?
Great question. So the first order of business is to check just the standard liver panel, AST and ALT, which are often elevated, but not always. But I think a bigger sort of risk or tip-off is patients with type 2 diabetes. We've learned now that up to 70% of type 2 diabetics have some abnormal fat or stiffness in the liver. And so we now routinely recommend that patients with type 2 diabetes be screened for underlying liver disease by liver tests and starting with an ultrasound. For patients who have likely MASH, and we don't routinely do liver biopsies to establish it if the conditions are typical of MASH. So, for example, if a patient has that full-blown metabolic syndrome, obesity, hyperlipidemia, type 2 diabetes, and they have fat in their liver, we assume generally that they have MASH. Typically, in those patients, we'll go one step further and do a test at the bedside or in the practice setting called liver stiffness, or one of the commercial vendors is FibroScan. There are others that measure liver stiffness, and liver stiffness turns out to be a good corollary for how much scarring is going on in the liver. It's a very easy, painless test, non-invasive. So increasingly, in patients who either are at risk or who have elevated liver tests, we'll turn to a liver stiffness test next to try to get a sense of where they are. That can be complemented by more specialized blood tests as well, so that you get a clearer picture not only of the presence of MASH, but also the likely stage of progression.
And is the degree to which the liver presents as stiff related to the extent of fibrosis in the liver?
Absolutely. So in this setting, because fibrosis is kind of a ropey, dense scar, the more scar you have, the stiffer the liver. And the way these tests generally work is they emit a painless pulse, and that sound wave can be, or the wave can be tracked as it traverses through the liver using a probe over the liver. The faster the pulse travels, the stiffer the liver. And so there are good cutoffs now that are pretty reliable for using stiffness tests as a way to start to stage the amount of scarring. The key issue here is that we want to identify patients not who have just fat alone, but those who have begun to accumulate scar and inflammation, because ultimately over many years this can lead to cirrhosis and the risk of liver cancer. The good news is we progressed to the point where we now have an approved therapy, at least in the United States, which is a thyroid hormone beta agonist, beta-1 agonist, that was actually originally developed to lower blood lipids. In the US, it's marketed by a company called Madrigal. I have no relationship to the company. And the drug's name commercially is Resdifra. And so we at least now have something to offer patients, but I'll tell you that's just the tip of the iceberg, so to speak, in terms of new therapies. There are literally dozens of new therapies targeting MASH and the consequences therein.
How long does it take to progress from having MASLD to MASH? Does it take a period of months or probably years?
Probably years, but it really depends. It depends in particular on the risk factors. So there are some genetic variants that are particularly prevalent, for example, in Latino Americans and indigenous South Americans. And those gene variants can accelerate progression to disease. Probably the most dramatic example of rapid progression, however, is in children. And so there's a frightening increase in the prevalence not only of MASH in youngsters and teenagers in particular, but a rapid progression to advanced fibrosis and even cirrhosis in some young people. And so in that setting, it can be a matter of just a few short years, probably 3 to 5 years, maybe a little bit longer, but much faster than in conventional adult cases.
That's shocking. And is this as a result of the fact that their liver, as a proportion or a ratio to their overall body size, is larger compared to an adult?
Not exactly. That's an interesting concept. I think it's really more the other way around. The liver accumulates fat and enlarges, and maybe out of proportion to the body, but it's not clear that the body weight influences the liver as much as the liver influences the body weight.
Is it possible to reverse any of these conditions? And if so, again, how long would that take?
Great question. The best example or the best knowledge we have about reversibility comes from studies of bariatric surgery in severely obese patients. So to remind you and the listeners, these are surgical techniques to reduce intake and in many ways shorten the amount of available intestine to absorb nutrients. It almost always results in significant weight loss. And what we know is that the disease can reverse as long as the patient doesn't have established cirrhosis or the very advanced state. So in bariatric surgery, for example, if you have a patient who has sort of medium stages or intermediate stages of scarring or fibrosis, within 1 year, they'll have improvement in the inflammation, and it takes up to 5 years to get improvement in the fibrosis. But during that time, they're getting better, not worse. It's also possible that drugs that prevent the scarring to progress to the most advanced stage will be effective as well, because we know that patients, until they have cirrhosis, they don't really have any severe consequences of the scarring. So if we develop drugs that can simply freeze the disease, even if it doesn't regress it, that may be sufficient. Currently, the drug that's approved, Resdifra, can actually improve fibrosis, and that's been largely established in patients who do not have the most advanced stage of cirrhosis. I believe that reversing scarring in cirrhosis is a higher bar and going to be more challenging, but ultimately I'm confident we'll get there.
Given that these diseases are strongly tied to metabolic dysfunction, as we said at the outset, how significant are diet and lifestyle in preventing them in the first place?
They are quite significant. Part of the the constellation of causative factors includes a change in our diet and a reduction in exercise. So, for example, obviously our predecessors or our ancestors were much more active and ate less carbohydrate-rich foods. And so diet and lifestyle can have a meaningful impact on the disease. The challenge, as I'm sure many are aware, is not just losing the weight through improvement in diet and exercise, but sustaining that weight loss. Because it seems that in some ways our hormonal and neural signaling is pre-programmed to drive us to become more obese to a greater extent than it did 30 or 50 years ago. And so it's often felt that we're kind of changing the set point and making obesity more of a normal state in terms of our neural and hormonal physiology, so that you can defeat that with diet and exercise, but sustaining that over years becomes very challenging because our system is conspiring to bring us back to an obese state.
I have read that patients with MASLD and MASH are at a higher risk of cardiovascular disease. Is this the case, and is this because poor liver health influences heart health, or is it simply the case that both organs will suffer if a person's diet and lifestyle are unhealthy at the same time?
Yes and yes. So let me answer that. The risk of cardiovascular disease in patients with MASH is significant. And in fact, until patients are cirrhotic, their most immediate risk of death comes from cardiovascular disease, coronary artery disease and stroke and other vascular abnormalities that come along with hyperlipidemia. What's less clear, and those are occurring in parallel to the accumulation of fat, what's less clear is how much the fat in the liver and the disease in the liver is also driving more cardiovascular disease. There's good evidence that that's the case. We don't know the quantitative contribution of the liver specifically to accelerating cardiovascular disease, and therefore we don't know what the impact of improving MASH will be on the risk of heart disease and stroke. But they're clearly partnered in terms of comorbidities, with cardiovascular disease being a higher cause of death and less patients have advanced disease of the liver or cirrhosis. Once patients have cirrhosis, then their most immediate risk comes from complications of liver disease primarily, including a growing risk of hepatocellular carcinoma or primary liver cancer, which can be a very catastrophic diagnosis in patients with MASH. And it's not unusual for the first manifestation of MASH to be that patient presents with symptoms that reflect an underlying cancer without even knowing they had underlying MASH first.
Do you think that the large numbers of cases of these versions of fatty liver disease that we've been talking about constitute a healthcare crisis? And what steps do you think that the authorities should be making in order to get that message across?
Oh, absolutely. The economic cost and the lost work and the impact on quality of life of this disease is extraordinary. And there are some very good studies now that predict the healthcare expenses that are going to be devoted to this illness and associated illnesses is going to balloon between now and 2040. So we need to really do something. There has been an effort by both professional associations in the U.S. and in Europe to get this on the radar of public healthcare agencies, particularly in the U.S., the Center for Disease Control, but also in Europe and throughout the world by the World Health Organization. So this has really been off the radar of those organizations in many ways. Perhaps one of the reasons is because once you diagnosed it, there was nothing to offer until recently. But now, with the availability of an effective therapy and more on the way, I think there's even more compelling reason to screen for this disease so we can intervene in a time that will prevent complications of end-stage liver disease and cardiovascular disease.
Going from the authorities then to the patients, finally, I want to ask you this question. What message would you have for the audience today who are probably hearing these terms for the first time? So how can they optimize their own liver health going forward?
Very important question. And I think the simple answer is for patients who already have cardiovascular disease, and in particular for those who have type 2 diabetes, they absolutely should be screened for underlying liver disease. And they should bring it to the attention of their healthcare provider if the provider doesn't bring it up first, because we need to educate the providers as well so that they know that type 2 diabetics in particular are at higher risk and should be screened, even if they have no symptoms associated with liver disease. Beyond that, patients who have features of the metabolic syndrome, and in particular obesity, should be aware that there is a lurking risk of liver disease and bring that to the attention of their healthcare provider. In the meantime, of course, improved diet with less carbohydrate, more protein, and more activity and regular exercise are always good advice, and certainly especially true in patients who are obese. So I think that's where we are now. There are no, I would say, coordinated, or there are not sufficient coordinated efforts to screen patients more broadly. I think those are likely to come. And we saw a similar sort of natural history of diagnosis and treatment in the case of hepatitis C, which we've almost cured throughout the world because we had effective treatment. So once the effective treatments were well known, it became much more compelling to screen for that disease because we had cures. In the case of MASH, we don't have cures, but we do have effective therapies, and so screening becomes even more compelling.
Well, liver health is such an important topic. I'm very happy to have the experience of your knowledge on the podcast today. Professor Scott Friedman, thank you so much for your time.
My pleasure.
If you enjoyed that video, I know you'll get some value from this video right here.